The subcommittee will come to order. Chair recognizes himself for 5 minutes for an opening statement. During the 2008 campaign and run-up to passage of the Affordable Care Act in March of 2010, President Obama repeatedly promised the American people that their health care premiums would go down by an average of $2,500 before the end of his first term in office. Unfortunately, he broke that promise. In fact, Americans' premiums have already risen by more than $3,000, and the expensive part of the ACA hasn't even been implemented yet. It is basic common sense that if you require individuals to buy a one-size-fits-all government-mandated health plan that covers everything, rather than allowing individuals to pick the plan that best fits their needs, choice will be limited and premiums will rise. When Obamacare adds mandatory benefits, regulations like guaranteed issue and community rating, and new taxes and fees on insurance plans, premiums will only grow more unaffordable for Americans. So unaffordable, in fact, that the authors of the law decided the only way to get people to buy health coverage was to force them to buy it or face a fine from the IRS. Now, my friends on the other side of the aisle will point out that the ACA includes subsidies to help individuals buy these more expensive health plans, and they are correct. More than $1 trillion in subsidies is available for this purpose. However, households earning as little as $46,000 will be ineligible for premium assistance. Even after receiving subsidies, Americans earning as little as $25,000 will still pay more for their health insurance than they would if the ACA had not been enacted. Making low-income and everyday Americans pay more for private health coverage is not health reform. It's making their life harder at a time when our fellow citizens face sluggish economic growth, slow job creation, and little disposable income. I recommend to all of you a report released last week by Energy and Commerce Majority staff entitled "The Price of Obamacare's Broken Promises: Young Adults and Middle-Class Families Set to Endure Higher Premiums and Unaffordable Coverage." The report compiles data from over 30 studies and analysis that examine the effect of Obamacare provisions on health care premiums in the individual and small group market. It also includes a state-by-state analysis of estimated increases in individual market premiums that can be directly attributed to Obamacare. My home state of Pennsylvania can expect to see premiums in the individual market rise about 39%. States such as Arizona, Arkansas, Georgia, Idaho, Indiana, Iowa, Kentucky, Missouri, Ohio, Oklahoma, Tennessee, Wisconsin, and Wyoming could see individual market premiums rise as much as 100% or higher due to the Affordable Care Act. The increases for young adults in the individual market are much higher. One analysis estimates that 80% of young Americans earning over $16,000 will pay more for their coverage once the law is fully implemented than they pay today. And we don't have to rely merely on estimates of what is going to happen to premiums. Many of the provisions of Obamacare, such as an individual mandate, guaranteed issue, and community rating, have been tried before. Premiums skyrocketed, choice was limited, and these Obamacare-style reforms made it harder to find affordable coverage. In today's economy, American families simply cannot afford to pay higher out-of-pocket health costs than they would if Obamacare had never been enacted. Our young people, many of whom cannot find jobs, cannot afford triple-digit increases in their health premiums. A central promise of the Affordable Care Act is that health care would be more affordable under the law. For many middle-class families and young adults, that turns out to be a broken promise. I look forward to hearing from our witnesses today. I'm interested in what their research shows will happen to premiums when Obamacare is fully implemented in 2014. Thank you, and I yield the balance of my time to Dr. Gingrey here. Anyone seeking 1 minute? All right, if not, I yield back the balance of my time and At this point, Chair, recognize the ranking member of the full committee, Mr. Waxman, for 5 minutes for an opening statement.
Thank you, Mr. Chairman, and I thank Ms. Capps for letting me go ahead of her and making my opening statement. My Republican friends want to ignore the broken health care system we had before the Affordable Care Act. They want to ignore the tens of millions of Americans who will finally have access to affordable care coverage in 2014, and they want to ignore the fact that for the overwhelming majority of Americans, health reform will result in much more affordable coverage. Well, I think ignoring these facts is an exercise in willful ignorance. In the world before the Affordable Care Act, nearly 50 million Americans have been uninsured. Millions have been losing coverage every year. Millions more were excluded from coverage because of insurance company discrimination, and lacking coverage was a life-threatening condition. While tens of millions of Americans suffered in this broken market, a tiny segment of the population was able to purchase cut-rate, low-quality coverage. When insurance companies have to provide real coverage to every American, this small group of people will no longer benefit from insurance companies' rampant discrimination. Republicans and their allies in the insurance industry have taken deeply flawed studies of this issue and tried to argue that health reform will drive up everyone's premiums. Well, that's a false claim, and I think it's irresponsible. Their claims are false because they're based on studies that ignore key pieces of the health reform legislation. Under the Affordable Care Act, consumers will be able to purchase far more valuable and dependable coverage, and there will be limits on the overall out-of-pocket spending that insurance companies can demand. Ignoring these reforms gives a deeply misleading picture of the true cost of coverage. For young people in particular, the subsidies in the Affordable Care Act, the law's new catastrophic plan, and the ability to stay on a parent's plan until age 26 will all help keep costs low. Studies that ignore these factors do not reflect reality. The reality is that the vast majority of Americans will see their premiums stay stable or decline dramatically in 2014. Prior to reform, Americans could be locked out of coverage entirely based on a pre-existing condition. They were routinely asked to pay 5 or even 10 times more than their neighbors for coverage because of their age, their gender, or their health status. For these millions of people, the reforms in the Affordable Care Act will bring costs down dramatically. That is the true story of how premiums will change under the Affordable Act. We all know how important it is that every American sign up for health insurance. They'll have this opportunity at the beginning of next year. It's been documented again and again that people who go uninsured are more likely to get sicker and to die younger than people with insurance. We need to be encouraging our constituents to get covered, not scaring them off with warnings about government-run health care and a radical spike in premiums. It's past time that we in Congress work together to help smoothly implement this law. I hope that after this hearing we can move beyond political messaging to carry out the real work that the people sent us here to do. Certainly we ought to exercise our oversight, but oversight is looking at what's happening and trying to change the situation to make the laws work, not to still complain about the laws that you fought against and lost. This law has been adopted by the Congress and signed by the President. It has been reaffirmed by the Supreme Court of the United States, and more importantly, the people's votes in this last election re-elected President Obama and Democrats to continue to support this legislation. I don't think the The majority in this House ought to see its job to continue to relitigate the legislative fight. Let's learn from realities as they will now unfold and try to make things better for everybody. Yield back my time.
Chair, thanks, gentlemen. Now recognize the Vice Chairman of the Subcommittee, Dr. Burgess, for 5 minutes for an opening statement.
Thank you, Mr. Chairman. And of course, listening to the ranking member does remind me of everything that's happened over the past 3 years' time. And yes, I will admit guilty as charged to having opposed bad policy at every turn. But isn't it interesting, as we sit here this morning on the eve of the third year of the signing of this bill into law, that the greatest obstacle to its implementation is actually the administration itself. And why do I say that? Well, first off, when the law was crafted, it was special interests down at the White House who actually wrote the law. The insurance companies, the pharmaceutical companies. Where were the governors? Why weren't they involved? Governors have a big footprint in their states as far as health care delivery is concerned. Why were they not consulted? Of course, you had the game of hide the ball. And Gary Cohen all but admitted it when he came to our committee a few months ago, and said the administration did not want to put out the rules about the essential health benefit until after the election because they didn't want to distract people. Well, governors needed to know that information. That's why none of them signed up for the state exchanges. And then finally, to get someone from the administration in here to our committee to do the proper oversight of the implementation, I just do not understand why it's so hard. But to the business at hand this morning, we've all talked about how the Affordable Care Act was supposed to decrease health insurance premiums. I'm going to tell you, in healthcare, you don't get something for nothing. There's always a cost, and someone always pays it. The Congressional Budget Office and organizations on both sides of the dais have predicted drastic increases in insurance premiums for the coming years. The Congressional Budget Office predicted average premiums will rise 27 to 30% because of the Affordable Care Act. And we don't just have to rely on their projections. History demonstrates the negative impact of such insurance provisions. The 1990s saw huge premium increases after enacting policies that we now know as guaranteed issue and community rating. When the federal government subjects health insurers to price controls, excess regulations, and mandated coverage requirements, insurers must make up for the added cost because unlike the federal government, health insurers cannot run perpetual deficits, so they turn to their ratepayers to provide the additional funds. Those with the highest uninsured and unemployment rates in the nation, individuals under the age of 40, will see their premiums increase the most, 40 to 200% according to some estimates. The Congressional Budget Office and a wide range of experts have warned us from the beginning of the impending rate shock, yet Congress has failed to act. Today we'll see another way the President's Affordable Care Act is anything but affordable for all Americans. And I'd now like to yield the balance of the time to Dr. Gingrey.
I thank the gentleman for yielding, and I thank the chairman for calling this hearing today. I commend the committee for, again, looking at how Obamacare will impact our country's health care. Earlier this week, we heard how various provisions raise the cost to do business. Today, we will now hear how it raises costs on individuals looking to purchase insurance. The economic downturn and slow recovery has hit young Americans particularly hard. The unemployment rate for young individuals has risen higher than the national average. If a 20-something is lucky enough to have a job, he or she is likely to be underemployed with little prospect for advancement. Many are left with the inability to obtain health insurance through an employer, his or her parents, or Medicaid. The grim reality has left young people with few affordable options when it comes to health care coverage. In fact, more than 5 million Americans in their 20s are presently without health insurance. 5 million Americans in their 20s are presently without health insurance. The age band compression in President Obama's health law will exacerbate this problem. And I ask you, Mr. Chairman, if our goal was to improve the rate of individuals who have insurance in this country, why on earth would we deliberately make it more expensive to obtain? The fact is that a 27-year-old earning as little as $33,500 a year will see her premiums jump nearly $800 next year. We need to implement real reforms and bring health care costs under control. We need to lower costs for young, healthy adults, not force them to subsidize costs for the older and more established Americans who can better afford. Mr. Chairman, finding a way to lower health care costs for young people is not a partisan issue. It's a patient issue. We must continue to work together to ensure a healthier future for all Americans. And I look forward to working with this committee to repeal this discriminatory provision of age banding, and I'll do that with the Liberty Act, and I ask for bipartisan support in co-sponsoring my Liberty Act, and it does just that. Thank you, and I yield back.
Chair thanks the gentleman and now recognizes gentlelady from California, Ms. Capps, for 5 minutes for an opening statement.
Thank you, Mr. Chairman, and I welcome our witnesses for appearing today and look forward to your testimony. Today, we are rushing to fit in yet another hearing on Obamacare, citing fuzzy figures and speculation and ignoring the context of the failings of our previous health care system and the opportunities that we now have thanks to Obamacare. Now we have the opportunity to work together on this committee to make sure that the ACA is implemented correctly. I am sensitive to the fact that this law changes the landscape of health care, and that is the point. Our previous system was fundamentally flawed, as this committee found in detail on numerous hearings. It was a system that allowed insurers to routinely deny coverage for even the most minor pre-existing conditions, like previous sport injuries, pregnancy, or even hay fever. It was a system that would drop coverage when families needed it most, or impose arbitrary lifetime coverage limits, leaving families who thought they had coverage in serious medical debt, worrying about how to pay the bills more than how to get better. And it was a system that allowed insurers to discriminate against the elderly and against women, charging them dramatically different rates or refusing to cover them at all, even when the vast majority of those plans offered no substantial special benefits, even such as basic maternity care. Seems like we've already forgotten just how dysfunctional our previous system was for millions of Americans who were denied any coverage, whether it was affordable or not. So I'm hopeful that both sides will use this opportunity today to highlight the vast consumer protections that help affordable health care coverage become a reality for millions of Americans. Now, starting in just a few months, health insurance companies cannot not any longer deny coverage or refuse renewal if you happen to get sick. And thanks to the law, they have to actually use your premiums to provide health care or give it back. These rebates have already reached 13 million Americans. And women will no longer be legally discriminated against and charged more for their premiums just because they are a woman. The title of today's hearing implies health insurance premiums are somehow only now a problem, conveniently ignoring the fact that premiums have been rapidly increasing for many years. Yes, in the pre-reform market, premiums were held down artificially low for some policyholders, but that came at the expense of people having no real coverage at all when the unexpected medical bills arrived, and at the expense of millions of Americans being excluded from any coverage at all. So looking only at premiums is short-sighted and misleading. Moreover, premium costs are far from the full story. Low premiums are an illusion that routinely mask high deductibles and cost-sharing amounts that are just as significant, if not more costly, than the premiums themselves. New out-of-pocket maximums will limit total spending, and consumers are now guaranteed a minimum set of benefits, like preventive benefits without cost-sharing, which means that plans are now more valuable. These plans now value and support our health and wellness instead of just waiting for us to get sick. And premium tax credits, reducing cost-sharing, and provisions directed specifically for young adults will help keep insurance affordable. On top of all these benefits, the facts are simple. The ACA has not caused widespread premium increases. The vast majority of consumers will see continued premium stability, and millions will see lower total costs right away. So I hope today we can keep the issue in perspective and don't simply resort to the scare tactics that have become so commonplace. I believe we should continue to move forward with reform. The millions of Americans who have been waiting for health insurance cannot afford for us to go backward. Since I have a minute remaining, I'll just remind the previous speaker, Dr. Gingrey, that now under the coverage of the ACA, young people under 26 can stay on their parents' plan, and many thousands of them have already been taking advantage of that basic coverage within the ACA. And I yield back the balance of my time.
The gentlelady yields back. I'd like now to introduce today's witnesses. We're very happy to have with us this morning a very erudite and experienced panel. Dr. Douglas Holtz-Eakin is the former director of the Congressional Budget Office and serves as the president of the American Action Forum. Mr. Wendell Potter is a senior analyst at the Center for Public Integrity. Christopher Carlson is an actuarial principal for Oliver Wyman. Dr. Holtz-Eakin, you are recognized for 5 minutes for the purposes of an opening statement.
Chairman Burgess, Congresswoman Capps, and members of the committee, thank you for the chance to be here today. I do have a written testimony that I've submitted. Let me just make 3 points briefly, and then I look forward to your questions. Point number one is that there are provisions of the Affordable Care Act that would lead one to believe that it would have an upward impact on premiums, and that point number two, in order to see the magnitudes involved, we've actually undertaken some survey research and asked insurers what their actuaries are telling them about the implications for those in individual and small employer markets. And then finally, given the evidence that there will be upward pressure on a large number of premiums, what are the implications of that more broadly for the Affordable Care Act and for the federal budget? And I want to talk a little bit about each of those. First, the provisions I think the committee is quite familiar with. There's the combination of guaranteed issue, the inability to exclude on the basis of pre-existing conditions, community rating, which excludes rating on the basis of health status or gender and limits age rating bands to a 3-to-1 ratio, the new essential health benefits, a minimum benefit package that must be adhered to, and then the overall mandate for individuals and employers to provide coverage and to carry coverage for the individuals. Those provisions, plus some others in the Affordable Care Act, the basic coverage itself will increase the demand for medical services, raise pressure on prices from providers across the nation, and thus on the underlying trend of cost care growth, and a whole series of taxes that are included in the Affordable Care Act, which will be embedded into the premium structure and raise premiums as well. If you take all of those, no individual one is particularly novel. We've seen some of this, as the chairman mentioned in his opening statement, in the states, but the experience there is not one that would lead you to think that there's going to be downward or stable premium pressures. Instead, the experience has been one of upward premium pressures where these have been tried in the past. That's all either history or conjecture, and we've done modeling, and others have as well, but we thought the useful thing would be to go find out. And so in the testimony I submitted are the results of a survey. That survey was sent to large insurers in the United States. The insurers were asked to fill out very specific questions about individuals, a young, healthy individual in 6 particular states and markets: Chicago, Illinois, Phoenix, Arizona, Atlanta, Georgia, Austin, Texas, Milwaukee, Wisconsin, and also for older, less healthy individuals in either the individual market. And then we did the same exercise for the small group market. The insurers who were asked to fill this out cover the vast majority of covered lives in the United States. So while I don't represent this as sort of some sort of representative sample of the insured population, this is a good indicator of what's going on out there. I won't belabor every single number in the results, but in the tables we find that if you look at the younger and healthier workers across those markets, the average premium increase is going to be about 149%. As has been noted, not every premium is guaranteed to go up. Some of those provisions will, in fact, subsidize older, sicker workers, and we see modest reductions in their premiums. Our estimate's 26%. In the individual market, you get even bigger impacts, 189% increase for the young, healthy workers, less modest redistribution, small downward, 18% in the premiums for the older and sicker workers. So I think that tells us that the basic intuition about the structure of the Affordable Care Act is playing out in the market. We're going to have a combination of legislative provisions plus market pressures that will lead to higher premiums for certainly the plurality of the insured, who are the young and healthy, once the Act is fully implemented in 2014. And I guess I would say that there are a couple of implications for that. Implication number one is the question about individual take-up. The law relies heavily on a tax penalty to enforce the individual mandate to carry insurance. Given the sharp increases in premiums and the basic calculus that individuals can do, will they in fact take up the insurance and enter the risk pool, or will they remain outside of it, pay the tax penalty? If so, the experience will be much like the states who had guaranteed issue and community rating and sharp premium increases. For employers, the sharp premium increases increase a second piece of the calculus, which says, we're not going to provide the coverage. We will instead send our employees off to the exchanges to get insurance. And to the extent that that takes place, we will see the Congressional Budget Office estimates of the costs of the Affordable Care Act be lower bounds, and instead larger exchange take-up will lead to expanded budget cost, and the higher premiums will increase the subsidy per person, exacerbating the overall budgetary impact of the Affordable Care Act. So I think this is an important issue, and I'm privileged to have the chance to be here today and look forward to answering your questions.
The gentleman yields back his time. Mr. Potter, you're recognized for 5 minutes for the purposes of an opening statement.
Thank you, Mr. Chairman and members of the subcommittee. It's an honor to be here today. If I may, I'd like to begin with an apology to the family of Leslie Elder. Leslie died an untimely death at age 83 last summer, uninsured and facing foreclosure. I owe her family an apology because Leslie might be alive today had it not been for the work that I used to do. You see, I helped create the same kind of deceptive PR campaigns that are being waged today to weaken the consumer protections in the Affordable Care Act. The campaigns I helped create intentionally misled the American people and their elected officials into believing that the reform of our health insurance system would do more harm than good. Among the tactics we used was hiring consulting firms and think tanks to conduct studies and surveys using questionable methodology and disclosing only the findings that could be useful talking points. These campaigns helped maintain an unacceptable status quo in which too many Americans have had to declare bankruptcy, lose their homes, and, like Leslie Elder, die much too young. Leslie's daughter believes her mother would be alive today if she had been able to get health insurance. But no company was willing to sell her an affordable policy because of her age, her gender, and ultimately her serious but treatable illness. There have been an untold number of Leslie Elders who have died prematurely because of insurance company practices that the Affordable Care Act thankfully is ending. The latest scare campaign has insurance companies professing concern about young adults, but what they really worry about is no longer being able to cherry-pick the youngest and healthiest. In most states today, insurance companies are able to charge older people like Leslie 5, 6, or even 10 times more for the same coverage they gladly will sell to younger, healthier people. And in some states, there's no limit at all. One of the reasons we're here today is that the Affordable Care Act prohibits insurers from charging older people more than 3 times as much as they charge young adults. This new age rating ban foils attempts by insurance companies to deny coverage to people they want to avoid, people like Leslie Elder. Of course, the current coordinated attack on the law fails to consider many important factors, and as a result, the studies being cited in this campaign intentionally mislead the public. Here are some factors that the insurance industry is not talking about, but that a recent and unbiased Urban Institute analysis confirmed. Only a small percentage of young adults will be affected, while many people at the other end of the age band will see benefits that allow them to stay covered and maintain their health. There are many serious deficiencies in today's coverage, especially in the low-value, minimal benefit coverage that's being marketed to young people. Banning junk insurance policies, those that are offered even by the biggest companies, while maintaining access to low-cost policies, will mean that Americans will be able to purchase real coverage that protects them from financial ruin if they happen to fall ill. Discriminatory practices have for years priced many people out of the market, allowing for artificially low premiums for others. And finally, premium tax credits will soon be available that will dramatically reduce costs for many consumers. In fact, coverage under the Affordable Care Act will be more affordable for the vast majority of young people because of the Medicaid expansion, the premium tax credits for low to moderate income earners, and the ability of young people to remain on their parents' policies until age 26 if they don't have jobs with health benefits. Adults under 30 will also be able to purchase catastrophic coverage with lower premiums and higher deductibles. And keep in mind that millions of young adults who have employment-based coverage will not be affected at all. The title of today's hearing is Unaffordable: Impact of Obamacare on America's Health Insurance Premiums. The title implies that before the Affordable Care Act came along, premiums were stable, but now are on the verge of skyrocketing because of the reform law. Nothing could be further from the truth. But my former colleagues in the insurance industry are hoping that you'll either have amnesia or turn a blind eye to the fact that premiums truly were skyrocketing before the Affordable Care Act. The average family premium increased an astonishing 131% between 1999 and 2009. That's more than 3 times worker wages, 4 times general inflation, and considerably faster than overall medical inflation. I ask Congress not to buy into the insurance industry's PR campaign. The vast majority of young adults will benefit from the law. Many, for the first time, will be able to get decent, affordable coverage that will enable them to stay healthy without fear of financial ruin. Mr. Chairman and members of this committee, many of your constituents have been counting the days until January 1, 2014, when insurance companies will no longer be able to deny them coverage or charge them far more than their family budgets can handle. Please do not dash their hopes. If you change the Affordable Care Act to enable insurance companies to meet profit goals, and that's what's really going on here, helping them to meet profit goals, then the results will be tragic, and many of your constituents will continue to be at risk of dying prematurely, like Leslie Elder. Thank you.
Gentleman's time has expired. The chair recognizes Mr. Carlson, 5 minutes for purposes of an opening statement.
Mr. Chairman and members of the subcommittee, thank you for this opportunity to testify on the impact of the Affordable Care Act on health insurance premium rates. My testimony will focus on 2 topics that I and the other actuaries at Oliver Wyman have studied extensively. First, the estimates we have developed on the increase in premiums that will be required to fund the health insurer taxes beginning in 2014. And second, the analysis that we performed to measure the impact of the 3-to-1 age rating limitation of the ACA on non-group policies. Regarding the first topic, Oliver Wyman has researched extensively the impact of the health insurer taxes. We and others, including the CBO, believe that these fees will be passed through directly to policyholder in the form of higher premiums. Overall, we anticipate that these taxes will increase premiums by between 1.9 and 2.3% in 2014, increasing to between 2.8 and 3.7% in 2018. For the second topic, Kurt Giesa and I co-authored an article published in the American Academy of Actuaries magazine. The purpose of this article was to assess the impact of age rating limitations required by the ACA. Currently, in most states, health insurance premium rates are allowed to vary by a ratio of at least 5-to-1 based on the age of the individual. This is relative to actual costs, which may vary by as much as 6 or 7-to-1 based on age alone. Therefore, health insurers must compress the rates at the high and low ends to maintain the correct ratio of premiums based on age. There are certain things that our report says, and there are other things that our report does not say. To be clear, our report assumes that the average overall impact of age rating compression is a zero-sum game. Certain policyholders, those at the youngest ages, will pay more. Certain policyholders, those at the oldest ages, will pay less. But in the aggregate, for all policyholders, premiums collected with and without age rating compression will be the same. We do not say in our report that the premiums for everyone in the individual market will increase by 40%, as has been quoted. In fact, we expect that most people will see a decrease in the amount of premiums they pay, primarily due to the premium subsidies offered through the ACA. Our report is intended to measure the impact of age rating compression. However, we also make an assumption to the impact of all other provisions of the ACA. Specifically, the CBO provided an analysis of the health insurance premiums under the ACA in a letter to Senator Evan Bayh in 2009. In it, the CBO estimated that non-group premiums would increase by 10 to 13% relative to current law. This amount represents increases due to factors such as the actuarial value of benefits, competitive factors, and the enrollment of uninsureds. For our analysis, we assumed that the impact of these other factors would be at the low end of this range, or 10%. Our report illustrates the impact on premiums for those individuals that are not eligible for the subsidies. What our report shows is that for individuals in the lowest age bracket, ages 21 to 29, premiums would increase by 42% due to age rating and other factors, or 29% due to age rating compression alone. Further, individuals at ages 30 to 39 would see an increase of 31%, or 19% due to age rating compression only. At the other end, individuals at ages 60 to 64 would see their premiums increase by 1% for all factors, or decrease by 8% due to the age rating compression. There are several factors that should be considered when understanding the results in our report. First, our purpose was to illustrate one of the unintended consequences of the ACA. While most individuals will see their premiums decrease as a result of the premium subsidies available on the exchanges, there are certain individuals, primarily those under the age of 40 and that are not eligible for any premium subsidies, whose premiums may increase substantially due to the limitations on the age rating. Second, individuals under the age of 30 have an alternative to purchasing at premium rates that are affected by the age rating compression. They may purchase a catastrophic policy, which under the rules set by the Department of Health and Human Services, may have a rating factor that adjusts the premium to reflect the expected demographics of the enrollees. However, this severely limits the options available to younger individuals in selecting a policy. Mr. Chairman, again, I thank you for the opportunity to speak, and I look forward to answering any questions.
The gentleman yields back. We will now proceed to questions. I'll recognize myself first for 5 minutes for the purposes of questions. Mr. Carlson, let's stay with you. We've all seen the stories in the newspapers, warning of premium increases as a result of the Affordable Care Act. The Associated Press reported that premiums could more than double in some markets in states. We're asking you here today as an actuary, and we want to know about several provisions of the law and whether you believe that they will generally increase or decrease premiums. Do they make life better or worse? Got limited time, so I was hoping for one-word answers here. Premiums higher, lower, life better, worse. Yeah, your choice on how you respond, but a provision such as guaranteed issue.
Yes, it will increase premiums. It will certainly make life better for some, but from the perspective of the premiums, yes, it will increase premiums.
Coverage for rehabilitative services.
Yes, will increase premiums.
Coverage for habilitative services.
Yes, will increase premiums.
Coverage for oral and vision care.
Yes.
Limitations on cost sharing.
Yes, it will increase premiums.
Limitations on out-of-pocket maximums.
Yes, it will increase premiums.
Coverage for emergency services at in-network cost-sharing levels with limitations on things like pre-authorization.
Yes, will increase premiums.
Requirements related to annual limits.
Yes.
Requirements related to lifetime limits.
Yes.
Federal and state exchange administrative fees.
It may increase premiums.
The medical device tax.
Yes.
The health insurance tax fee.
Yes.
Yeah, and that's, and you mentioned this in your testimony. I mean, I guess the assumption of the people who were writing this was that things like the medical device tax and the health insurance fee those dollars would be taken from the chief executives of the company. But that's not the way the world works, is it? Those monies are actually collected from the ratepayers, ultimately, are they not?
Yes, they are. I mean, if you increase benefits, the premiums will go up. And if you increase costs to the insurers, those will have to be funded somehow.
Well, let's look at, proponents of the Affordable Care Act say the premiums spike as a result of these Affordable Care Act provisions will be offset by subsidies. You mentioned that in your testimony. Let's set aside for a moment the question of whether it makes sense to borrow $2 trillion from foreign nations to pay for a new entitlement when current Medicare and Medicaid programs are in trouble. Let us also set aside that lowering health care costs, according to some on the other side of the dais, means placing expensive regulations on what Americans must buy and offsetting some of the costs for people with dollars, and all of that comes from the taxpayers. Now, your study addressed this claim. At what income level are some younger Americans expected to start paying more as a result of the health care law?
Well, our study looks at the age rating compression, and individuals who are under the age of 30 who are at a federal poverty level of 225%, which is roughly about $25,000, they will pay higher premiums as a result of the age rating compression.
So that is the sort of the break point for an individual is $25,000.
Yes, yes, and above anyone above that level, their premiums will be affected by the age rating.
Very well. Dr. Holtz-Eakin, some supporters of the Affordable Care Act argue that the law's most expensive requirements will only follow in the individual market. And I remember the discussions in this room leading up to it. It seemed like our whole focus should be on people in the individual and small group market, but looks like we made things tougher for them, does it not?
Certainly these premium increases are going to be dramatic in the individual market for healthy individuals, certainly.
And we also heard from Ranking Member Waxman when he was giving his opening statement about the number of people who fall in the category of pre-existing condition and can't get insurance. Now, in the large group market, that was really much less of a problem, was it not?
Yeah, the HIPAA provisions were intended to solve that problem years ago.
So when he gives a figure of tens of millions of people who are unable to get insurance for a pre-existing condition, that number is probably a little bit overstated, is it not?
Some of the high-end dramatic ones simply are beyond the realm of possibility.
Well, and we know that it was a problem in the small group and individual market, and some states had risk pools and reinsurance to provide help there. The federal government set up a new program, and I remember looking at these numbers right before the Supreme Court ruled because I thought the Supreme Court was going to rule differently, as Mr. Waxman pointed out, and I thought we needed to be able to start talking about what happens to those folks who are in the federal pre-existing pool, and the number was startlingly small. It was not that they're not important people, but it was 65,000, nowhere near the tens of millions that had been talked about during the rhetoric. Is that a fair statement to make?
Certainly that's a fair statement. I mean, we, as you know, I've spent a lot of time looking at the high-risk pool design, and we didn't see anything like the take-up that was claimed.
Very well. My time has expired. Recognize the ranking member of the subcommittee, Ms. Capps from California.
Thank you, Mr. Chairman. Mr. Carlson, the chairman asked you if the provisions in the ACA make life better or worse, and your first answer was that yes, that guaranteed issue will make life better for many people. I just want to make sure that was clear for the record. Thank you, Mr. Potter, for your powerful story about Leslie Elder. As you know, your fellow witnesses today have produced faulty studies that ignore specific and key policies in the Affordable Care Act, which actually do help lower costs for all Americans, young and old. But the key thing they ignore is that the vast majority of this nation will benefit from an end to insurance company discrimination. A report by the National Women's Law Center detailed the pervasive discrimination women currently face in today's insurance market. The report revealed that the same health insurance policy can cost a woman 30, 50, even 85% more than a man of the same age, even if maternity care is not covered, which is in itself discriminatory. These higher premiums can have a significant impact on their budget, women's budget, costing a 40-year-old woman as much as $1,250 more each year than a man of the same age getting the exact same coverage. And let's not forget, women have often been denied all coverage just because they have a previous existing condition, such as pregnancy, or having had a C-section, or being victims of domestic violence. The Affordable Care Act ends these abuses by implementing landmark new protections for women and banning discrimination by insurance companies on the basis of gender or pre-existing conditions. Mr. Potter, can you tell us about the way insurance companies approached covering women, both young and old, prior to reform? You're knowledgeable on that topic.
Well, I certainly can, and the approach was to discriminate against women and people because of their age. And it's important to keep in mind that as we talk about community rating, in this country, that's how health insurance began. Virtually all of the Blue Cross plans initially were, their plans were based on community rating, which meant that everyone, regardless of age or gender or health status, paid the same amount. That changed when large insurance companies began to come into the market and see that they could cherry pick the youngest and the healthiest and make a substantial amount of money. And that is what has happened. And as a consequence of that, even the Blue Cross plans had to change the way they did business. And as a result, over the years, we've got a system that really discriminates, especially against people who, as they age, and against women. You're exactly right. And they do this because when you are segmenting the population that way, and you're often charging some people so much that they don't buy insurance. And that's why we have 50 million people in this country without coverage right now. And that helps their profits. When you have people who are discriminated against and they simply can't afford the policies because they happen to be born with a pre-existing condition called being female,
Right.
Then they can make a lot of money.
What do you think we can expect to happen to women's premiums after the ACA really kicks in?
They will go down. Insurance companies will no longer be able to single them out and say, just because you're a woman, you have to pay more than your brother or some other person who is of similar age but just happens to have been born male.
And do you expect this fall in premiums will be limited to women, or can other men and children, other issues be also covered in the same way in the ACA?
Oh, absolutely. Firstly, everyone. In fact, I do think that everyone will benefit from the Affordable Care Act and get some relief from price gouging. And keep in mind, too, it's important to, as we're talking about the individual market, we're talking about 14 million people. There are 315 million people in this country. And that means we're talking about a population that's about slightly more than 4% of the total population. And of that 4%, most of the people in the individual market will stand to benefit because they'll either be able to get coverage through the expansion of the Medicaid program, through the tax credits or subsidies for low-income earners, and for relief at the other end of the spectrum for people who've been charged up to 10 times or more for coverage in the past, to the point that many of them can't buy coverage. But at least we're talking about a very small segment of the population to begin with.
Thank you very much, and I yield back the balance of my time.
Gentlelady yields back. The gentleman from Texas, Mr. Hall, recognized for 5 minutes for questions.
Thank you, Mr. Chairman. Mr. Holt-Segan, beginning in 2014, the Affordable Care Act, the Obama Act, imposes a new tax on health insurance of at least $100 billion. That's an accurate figure, is it not?
Yes, sir.
I think it came that our committee got that from the Joint Tax Committee, so we can live with that figure. That's good to go with. Probably none of the three here deny that figure.
In fact, one of the unprecedented features of that tax is that it demands that a fixed amount of revenue be raised regardless of the circumstances in the industry. So $8 billion in 2014, no matter what.
And the tax begins at $8 billion in 2014 and rises to $14.3 billion in 2018, and thereafter it increases annually based on the premium growth. And I think we're all aware that the tax is going to fall on all individuals and businesses that purchase health care insurance. Maybe less well known is that or less well admitted by the writers of this act. The tax will also hit seniors enrolled in the Medicare Advantage plans, state Medicaid programs, and Medicaid health plans serving low-income families, right?
That's correct, sir.
And can you explain for the committee what kind of impact beneficiaries enrolled in the private Medicare and Medicaid plans can expect to encounter after the tax is fully phased in?
If you look at the structure of the tax, I think there's broad agreement that the tax itself will end up being embedded into premiums, that insurers will have to recover that cost, and the way to do so is raise premiums. A unique feature of the tax is that it is not deductible for purposes of paying corporation income taxes, something that I've never seen before in the tax law. So if you're not a tax-exempt insurer, if you have to pay $1 of insurance of the premium tax, and you raise your premiums by $1 to do it, you'll still come up short because you have to pay tax on that $1 as well. So you have to raise premiums by more than $1, actually $1.54 to cover that provision. That's a lot of upward pressure on premiums. Not everyone will be subject to that, so you'll start to see shuffling in coverage, shuffling in lines of business. The Medicare Advantage plans, the managed Medicaids are going to be subject to the same thing. That means disruption in provider networks, higher premiums across the board.
Well, thank you for that. Now, I didn't hear you say Medicaid programs. How will the tax impact the state Medicaid programs? Our governor was in town yesterday and discussed with the Republican members.
It is exactly the same. All these lines of insurance are subject to this, and all will see premium pressures as a result.
Then the yes answers that were extracted earlier by the chairman were based on services that increase or become more expensive. And either of those situations are what you glean from reading the Act itself.
Yeah, I mean, the tax is a cost the business have to cover, if I understand that question right.
I thank you. I yield back my time.
Someone yields back. Recognize the gentleman from Texas, Mr. Green. 5 minutes for questions, sir.
Thank you, Mr. Chairman, and this is not directed at you, but it's I guess I'm frustrated because I've been on this committee since 1997, and the Affordable Care Act was passed 3 years ago and upheld by the Supreme Court. And last session, all we did was try and repeal it, and that's not going to happen. It won't pass the Senate, and yet every hearing this week we've had is to talk about how bad it is. I would hope our committee would sometime get to the point where, okay, let's see what we can do to fix it. Instead of just making political points, we could actually pass legislation I think that's what everybody in the country would like us to do. But and this panel is a good example. You know, we have some great witnesses, and I've heard before on some cases, but you know, the Affordable Care Act's the law. And there are things in it I'd like to change, and I know everybody on the committee would, but we're not going to repeal it because it's not going to happen, at least for 4 years. But and so that's the frustration. Let's make it work, and there's some things that are really successful, and we really won't know until next year on the success of it. And when we see some of the requirements go in, there was a report released yesterday by my colleagues, my Republican colleagues, on prediction of premium increases under the Affordable Care Act. And the Republican report ignores the fact that over 90% of insured Americans have employer or public coverage, which is Medicaid or Medicare. And even an unbiased observer, including CBO, has said that 240 million people will not see their premiums increase under the ACA. And second, the American Action Forum study totally ignores the effect of premium tax credits. These credits would go directly to the cost of coverage, immediately lowering premiums each month, and the CBO has estimated the majority of the individuals getting coverage in the exchanges would receive subsidies, and it's deeply misleading to ignore the impact of those on effective premiums. Let me get to my questions now. Mr. Potter, is it accurate to compare a low premium plan to today's market with the type of quality coverage that will be available under the Affordable Care Act?
No, not at all, because a lot of the policies that are sold to people, and often people enroll in these unwittingly, are plans with very, very limited benefits or very high deductibles, and people often find out when it's too late that they're woefully underinsured. And one of the objectives of the Affordable Care Act is to make sure that people are getting value for what they buy, and that'll be something that we'll see as a result of the full implementation of the law. We'll no longer see people who are in junk policies because they'll be a thing of the past.
Well, I have a district in one of the highest in the country, at least the 2000 census. We haven't seen the numbers from the 2010 census. That are people who work, and yet they don't have insurance through their employers. And it's a very urban area in Houston, industrialized area. And for decades, outside of their job opportunities, the next thing they ask once they get a job is, what kind of health care do I get? And some employers offer very good health care. Some offer, as you said, very limited amount with high deductibles. Now, those are cheaper in premiums, but they also don't really establish what we hope in our healthcare world is a medical home where people feel comfortable going to, instead of, even with a high deductible, they're still going to show up at our emergency rooms because they don't have a coverage that will cover them. I know you worked in the insurance industry for a long time. Just out of curiosity, did the industry ever support outside research to help generate its public relations and drive its public policy agenda?
The insurance industry spends a considerable amount of their premium dollars on various public relations and lobbying efforts, but not so much on research that is all that reliable. The research is intended to make a point. You know, it's not necessary for anyone's premiums to go up. We need to understand that, because we're talking about changing the way these companies will do business. There will not be quite as much need, maybe not nearly as much need, for underwriting. McKinsey & Company did a study of healthcare costs around the world in 2008, and it showed in the U.S. of the administrative expenses of insurance companies, by far the largest component of that are marketing and underwriting expenses. And that's just not going to be all that necessary, because you're not going to be needing to use all that much those resources.
I'm almost out of time. And again, having served in the Texas legislature and tried to deal with uninsured, it was almost impossible. We created high-risk plans, but the only people who went to them were high risk. And the state wouldn't put any money in, so nobody could afford the coverage. So, you know, one of the best reforms in the Affordable Care Act is the 80% requirement that they have to pay out in medical benefits. I know physicians like that, hospitals like that, because they actually know that they're going to receive the payments. Mr. Chairman, I know I'm out of time, and I appreciate your patience.
The gentleman yields back. Chair recognizes the gentleman from Illinois, Mr. Shimkus, 5 minutes for questions.
Thank you, Mr. Chairman, and I'm glad my friend from Texas is just still in the room. I'd just like to remind him that we had not one hearing on this health care law before it was passed on the floor. There was not one, and then number two, I'll say, as ranking member of the Health Subcommittee, the remaining part of that year, every week I asked for the chairman of the Health Subcommittee to have hearings on how this law would be implemented, and we were never offered one. So what we're trying to do now is, at least, you know, it's the whole, you got to know we got to pass the bill before we know what's in it. Well, now we're trying to figure out what's in it, and that's what these hearings are part of. And you know, everybody's going to get a chance to ask our witnesses, and we're going to be able to make our points about the benefits and the disadvantages. But don't trash the system that legislators need to do, which is our oversight role in this body. And so I mean, I wouldn't respond so forcefully, except for I was the ranking member of the Health Subcommittee when this law got passed. Nathan Deal was it when the law was passed. Nathan left to run for governor. I assumed that role. And for the final part of that Congress, every week, I asked for a hearing on this piece of legislation. And every week, it was denied.
Well, would the gentleman yield?
I'd be happy to yield.
Well, you understand how it feels to be in the minority.
I definitely do. Yeah.
My quote was, you know, and you remember we had literally hours and hours, including very late markups on the bill. Now, having follow-up hearings, I agree. We should have had follow-up hearings on the implementation.
Reclaiming my time. Just reclaiming my time. The bill that was passed was the Senate bill, without hearings, without movement through the committee. It was picked up from the Senate and passed on the floor. I'm just telling you the facts.
And again, I agree that happened. The problem is that we didn't have an alternative. Believe me, the majority, no matter who's in the majority, and has that same thing.
Reclaiming my time, it was the speaker at that time who said, the American people, we have to pass the bill before we know what's in it.
Well, that wasn't my...
All we're trying to do now is to find out what's in this piece of legislation. So I applaud this series, because this is not even rolled out. It's not in full implementation yet. So that's, I mean, again, that's what we're trying to do. And I wanted to ask just Mr. Potter, and it's kind of key to this last comment about 80%, you know, has to go to services in the plan. And part of that debate was an analysis about how much administration plans that our Medicare system funds during the debate. And do you know what that percentage is of the overhead cost is the bureaucracy of Medicare?
Well, the medical loss ratio, the equivalent of that in the Medicare program is considerably lower than
Do you know what that percentage is?
I've heard that the administrative expense is about 3% in Medicare.
Okay, and that's the numbers that I use. That's the numbers my friends on the other side use. Now, can you tell me which health insurance plan, the private sector market or the government-run market, is actuarially unsound and going broke?
I think the current commercial system is absolutely unsustainable.
Okay, and the question is, Medicare or the private health insurance market, which one is going broke?
I don't know, sir.
Okay, let me ask Mr. Carlson. Do you have an idea?
Well, I certainly think that the commercial market is not going broke.
Oh, okay.
That's why they have actuaries to make
Right, and we haven't asked you. That's why they have actuaries, to make sure they don't go broke. Dr. Holtz-Eakin?
The government has actuaries, but it's still going broke, sir.
And that's really this part of this fight we're having in Washington, and how we can actually reform the entitlement programs so that we're not in a $16 trillion debt. Obamacare makes the program even worse because it creates a new entitlement that's not funded, that makes actuarially, sir, Mr. Potter, our nation less sound today, next year, and in the foreseeable future. I yield back my time.
Gentleman yields back. Chair recognizes Mrs. Sarbanes of Maryland, 5 minutes for purposes of questions, sir.
Thank you, Mr. Chairman. Dr. Holtz-Eakin, do you think the Affordable Care Act can work?
Sir, I'm sorry, sir, I didn't hear.
Do you think the Affordable Care Act can work?
I'm skeptical, to be honest, sir.
Okay. Mr. Carlson, do you think it can work?
I think there are things within the law that could be changed, but, you know, I can't comment overall whether it's going to work. And
It could work.
it certainly could work, and it may not work.
Americans could make it work, potentially, right?
How would you define work?
Mr. Potter, do you think it can work?
I do. I think it can work. I think that we will, as you bring more people into coverage, you make a big difference, and you begin to end some of the cost shifting that is so problematic in this country, and that contributes to all of us paying more in insurance premiums as a consequence.
Do you think the system we had before was workable over time?
Not at all. Not at all workable, nor unsustainable. It wasn't sustainable either. You cannot keep raising premiums. As I said, they increased 131% in between 1999 and 2009. You can't keep doing that, and you can't. And at the same time, insurance companies were shifting more of the cost of care from them and from employers to employees and independents. You can't keep doing that and expect that system is sustainable. It's simply not.
What I'm concerned about is we can all agree that there's going to be some increases for some portion of the population as a result of implementation of this. But we're talking about increases within that individual market for younger, healthier people who are more in a position to afford those increases than their peers might be, because if their peers can't afford it, they're going to be able to take advantage of these affordable care credits, these tax credits, when they go into the exchanges. So you're talking about a relatively small number of people who may experience, and I think arguably in an affordable way, an increase in their premiums. But based on that, we keep getting this phrase of a rate shock and so forth being bandied about. And I'm trying to figure out why that's happening, like what's afoot with it. So if the industry is the one that's putting out this rate shock narrative, when in fact there's going to be good stability for the great majority of consumers out there, and actually reduce premiums for many. If the industry's doing it, subscribing to this narrative, I can only surmise that they're doing it because they're getting ready or setting the table for some potential rate gouging. Now, if the industry's not intending to do that, and I'll give them the benefit of the doubt for the moment that they don't want to rate gouge, that they do just want to present the straight story on it, then what's really happening is that longtime critics of the Affordable Care Act are putting that narrative out as a way of just fear-mongering about the act generally. Do you, Mr. Potter, you've been there, you've been inside that mindset. What's going on here? Why are we getting this sort of rate shock narrative being pushed out to Americans right now? What do you think that's all about?
Well, the insurance companies spend a lot of money trying to influence public opinion, to influence public policy, and that's what's going on, is to create an impression of something that is not reality and is not likely to be reality. Keep in mind, too, that these may be, the increases we're talking about, may be what they would like to get and they would be able to get in the absence of the Affordable Care Act. But there are provisions in the law that will require reviews of excessive rate increases. And
thank goodness for that.
Yeah. So just because they say they want to do this or plan to do this doesn't mean they're going to be able to do this.
So at the end of the day, it's a completely non-constructive exercise.
It is that.
It achieves nothing to do this, to put that narrative out there. It just puts people on edge, and it's going to make it harder for us to make this thing work. And it can work if we put our heads behind it.
You're right. And keep in mind, again, we're talking, as you noted, about a very small segment of the population. But the intent here, when you're talking about rate shock, which is crock, if you ask me, is nothing more than to try to get the impression that we're talking about the whole population, and it is not that at all. Right. It is a small percentage.
Rate shock is a crock. Thank you. I appreciate that.
Gentleman's time has expired. Chair recognizes the gentleman from Louisiana, Dr. Cassidy.
Hey, Mr. Potter. If rate shock is a crock, why does Massachusetts, which has the beta version of Obamacare, which has exchanges, nonprofit insurance companies, i.e. no marketing apparently and no need to do actuarial testing, and has MLR requirements, they have the highest small business premiums in the nation. Now, it doesn't make sense to me that if the beta version is giving us this, that there won't be a rate shock.
Massachusetts is a great state. It's a prosperous state. It also has some of the best medical facilities in the country. But healthcare in Massachusetts is expensive. It's much more expensive in Massachusetts than in many other states.
So you don't draw a connection between the fact that they have Mass Health and the fact that they have higher premiums. It's just a function of the providers charging more.
Providers have always charged more in Massachusetts, so that's been
now
the
they've
case
had a
before.
rate of growth that exceeds the rest of the nation since putting in Mass Health. I think that's what it's called. So again, it's your position, though, that there's nothing inherent. They've got nonprofit insurance companies, et cetera, that there's nothing inherent in the plan that contributes to the upward pressure?
I think that in the plan, with the things that are in the Affordable Care Act, to mitigate the cost increases, you're not going to see necessarily, as I said, a lot of cost increases in this country.
Well, I guess we'll have to agree to disagree because Mass Health seems to belie what you're saying. Secondly, you spoke negatively of the plans that people could afford, right, suggesting that they're basically catastrophics. And let me just hold up the Kaiser Family Foundation. And Kaiser is kind of all in for Obamacare. But it points out that the average small business, or the average business, has an 80% actuarial value. We know from McKinsey that about 30% of businesses will dump their employees into the individual market. I mean, that's according to McKinsey's survey. And so then they'll probably choose the bronze plan. And the Kaiser Family Foundation study shows that these people will go from something of higher actuarial value to something of lower actuarial value, and that deductibles in the employer plans are about $1,900, but their deductibles, their out-of-pocket will be as much as $6,000 and higher for a family in the exchange. And they compare the bronze level plan, Kaiser Family Foundation does, with that of a catastrophic policy. So I guess if your position is the catastrophic policy is no good, and yet people will most likely be on a bronze level plan with a catastrophic type coverage, Are you indicting the bronze level plan?
No, not at all. The catastrophic plan, while not as generous and it will have higher deductibles, you're right, than the other plans, it still will be far better than a lot of the policies that are being marketed in this country. I've met people,
but again,
I've met people who are in $50,000 a year family policies with $50,000 annual deductibles. They pray every night they don't get sick.
So the nice thing about an HSA plan currently is that you can actually pre-fund on a tax-preferred basis, and you actually have that to meet your front-end cost. Under the bronze plan, there will actually be deductibles and copays that will have to be hit up to $4,000 before you get complete coverage. There is no first dollar coverage. I suppose the employer could elect to go to an HSA, but current rules are prejudiced against that. I think that we're hearing a mixed message from what you're saying and what the facts are. Dr. Holtz-Eakin, at a later time you can tell me why your name's hyphenated, but that's okay.
It's a long story and you don't have the time.
Listen, let's assume that what our colleagues say on the other side of the aisle, which I actually agree with, as long as President Obama is president, we're not going to repeal Obamacare. I mean, he's got too much invested. What could we do, if it is a law of the land, what could we do to bring premiums down?
Well, certainly the pressures in premiums come from the underlying growth in healthcare costs, and I think there's now a bipartisan consensus that nothing's really been done to break that trend. There's the layer that comes from taxes and mandates to raise those premiums, and one could modify those as well. And then the rest of the plan is just a large amount of puts and takes, because some people will do better and worse because we're going to redistribute from one group to another.
Let me ask you. I'm a big believer.
I
think empiric data shows that consumer-driven healthcare has lowered costs.
Sure.
Would you agree that if we could more encourage consumer-driven healthcare, that we'd have the same trend we've been having, that is lowering costs, that could continue under the ACA?
Allowing people greater choice to move toward plans that match their needs and provide some competitive pressure has always worked.
Okay. Mr. Chairman, I yield back.
Gentleman yields back his time. Chair recognizes Dr. Christensen, 5 minutes for purposes of questions.
Thank you, Mr. Chairman. And while we all agree that we could work to build on what the Affordable Care Act did to strengthen Medicare, I just want to make it clear for the record that Medicare is not going broke. Costs have grown by less than 2% over the past 3 years, and private insurance costs have really always grown much faster than that. Let me see if I can get two questions. And The Affordable Care Act takes a number of steps to ensure that Americans have access to quality, affordable coverage that's there when they need it. And these new protections, as has been discussed between you, Mr. Potter, and Mr. Green, offer stark contrast to some of the junk insurance that's on the market today, some of which is in my district, unfortunately. All the plans sold in the exchange will have an actuarial value of either 60, 70, 80, or 90%, and plans will have to cover essential health benefits and also offer preventive care with no cost sharing. So these requirements will significantly increase the value of insurance coverage for millions of Americans. The cap on out-of-pocket spending guarantees that individuals with serious health needs will never again face endlessly increasing cost sharing. In order to receive needed care, the end of lifetime limits on coverage and the phase out of annual limits ensure that coverage remains intact even if an individual's health care needs increase dramatically in a given year or as the individual grows older. So, Mr. Potter, all of these seem to me like common sense elements of quality insurance. So could you tell us why, in your experience, the insurance companies you used to work for are opposed to these reforms?
They make a great deal of money selling policies that are inadequate. And if you are selling policies, you don't have to pay very much out in claims, that goes right to the bottom line, and you're able to increase your profit margins.
And I guess that's why they're not going broke either.
That's why they're not going broke, and they're able to maintain their profit margins because of pressure from Wall Street. They do these things, but and they've invested quite a lot of money. Some of the biggest companies buying smaller companies that specialize in limited benefit plans that can almost guarantee that someone is going to be underinsured if they get sick. Leslie Elder didn't plan to get breast cancer. My son didn't plan to break his hand last year and find, because he's in a high deductible plan, that he is paying a lot of money out of pocket. He, by the way, before the Affordable Care Act was passed, was told he was in the individual market, that his policy was going to be increasing 66% unless he switched policies and go into a policy that had a deductible that's 10 times what he'd been paying. So again, hindsight is a lot clearer than looking ahead. We know what has been happening and the price gouging that's been going on. And really, we're talking about profits here.
So when the insurance companies say they want to offer choice and provide new low-cost options, you're talking about these junk things.
That's exactly
that are
right.
being sold on the market for big profits. So for consumers and young and healthy enough to be able to afford coverage in the individual market prior to reform, the coverage they had was really only an illusion. Insurers raised rates, hiked up cost sharing, and disappeared when the consumers really needed them. And we saw this in many of the hearings that we had leading up to health care reform, of which there were many. A recent analysis found that the premiums in the individual market are so unstable that 80% of plans raised premiums above the price consumers were quoted when they applied for the coverage. This so-called affordable option of my Republican friends think existed before health reform are really unstable and unreliable. It's also wrong to call today's low premium plans affordable because of all of the other charges that hit consumers as soon as they actually need the insurance. And these plans set hard annual and lifetime limits on the amount of care coverage, which leaves consumers completely in the lurch if they ever have a serious medical need, as the person you spoke about. So, Mr. Potter, the studies my Republican friends are relying on today are focusing on comparing low premium plans available today to premiums and plans that will be available under the Affordable Care Act. Would these premiums likely have stayed stable and provided real coverage if a person got sick?
Oh, not in the old world, not in today's world. They would not have remained stable. We've seen premium increases over the years, and they would continue.
So, this is just another reason that comparing past premiums in the individual market to future premiums makes no sense. My Republican friends ignore the subsidies available to consumers. They ignore the key limits on cost sharing, which they compare when they compare real quality coverage to the bait and switch insurance available today. So I thank you for your answers, and thank you, Mr. Chairman. I yield back.
Gentlelady yields back. Chair recognizes the gentleman from New Jersey, Mr. Lance, 5 minutes for the purposes of questions.
Thank you, Mr. Chairman, and good morning to the panel. To you, Mr. Potter, I'm concerned about pre-existing conditions, as I know you are from your testimony, and I think we should work together regarding that issue. The Centers for Medicare and Medicaid Services recently announced that they were no longer accepting applications for the pre-existing condition program created by the health care law. And I think that this is a challenge that we have to work together to solve. I think this could lead to countless chronically ill Americans, including the vast majority of the rare disease community, from not receiving treatments. And I have the honor of chairing with Congressman Crowley of Queens in New York City the Rare Disease Caucus. And recently, our leadership here in the House on the Republican side, Speaker Boehner, Majority Leader Cantor, Whit McCarthy, Conference Chair McMorris Rogers, who serves on this committee, Chairman Upton, Chairman Pitts, and Dr. Burgess sent a letter to the President regarding the fact that the Centers for Medicare and Medicaid Services announced that they were no longer accepting applications for the pre-existing conditions program. I'm wondering what your thoughts might be as we move forward to try to address this issue together, since one of the promises of the Health Care Act was that this program would be put in place and that we would have solved this problem, but clearly we need to do more work on the area.
When you're segmenting, pardon me, when you're segmenting people with pre-existing conditions into high-risk pools, by their very nature, they're going to have people who are sicker and who will have higher medical costs. And one of the reasons why it's important to move to at least a modified community rating approach to providing health coverage is that you can broaden the risk for everyone. Keep in mind that people who are sick, who have pre-existing conditions and might look to get coverage through a high-risk pool, often may not be able to work. They may not have the ability to buy into a high-risk pool. One of the reasons why maybe we haven't seen as much uptake in the high-risk pools in the states is because the premiums are expensive, and the people who are sick and who need them just often simply can't afford to buy them. So we do need to make sure that people who have pre-existing conditions are taken care of. We're all in this together. I think that if we can look beyond our own current circumstances, we might realize that a friend of ours or a brother or a daughter or a son might have a pre-existing condition and have need for medical care. So we've got to look beyond our own current situation sometimes.
The $5 billion program created by PPACA was intended to help individuals with pre-existing conditions through January 1st of next year. And as I understand it, despite lower than expected enrollments, CMS announced that it would no longer enroll in individuals. And it seems to me this is a reminder, and there have been several, that the costs of PPACA are significantly understated, and those who may need help are no longer going to be able to enroll in the program.
It's possible, but also there's not a great deal of awareness, I don't think, of coverage that is available or the high-risk pools. Leslie Elder, as CNN reported, conceivably could have been enrolled in a high-risk pool in Florida, but she and her husband just simply were not aware of the existence of it. So at the end of her life, conceivably, she died after the Affordable Care Act was passed, and she might have been able to have enrolled in a plan that they could have afforded, but it just wasn't something that was available. They were aware of its existence.
It might have been available, but from your perspective, she was not aware that it was available.
That's what was reported, and her husband said he was not aware of it as well. I talked to him just recently, and he wasn't aware that it could have been available to them. So these are not states don't necessarily have large marketing budgets like insurance companies do.
I think we have to work on this issue together, and I'm sorry that PPACA has not reached its promise in this regard, particularly regarding the rare disease community. Of great interest to me, since I chair that caucus with Congressman Crowley of the neighboring state of New York. And I think we have to work together and do a better job. And I think that was the intent of the leadership position in a letter written by Speaker Boehner and our other leadership to the President as we try to solve this issue together. Thank you, Mr. Chairman.
The gentleman yields back. Chair recognizes a gentleman from Georgia, Dr. Gingrey. 5 minutes for questions, sir.
Mr. Chairman, thank you. I want to reflect back just for a minute on the line of questioning between Mr. Sarbanes from Maryland and also Mr. Cassidy from Louisiana with Mr. Potter. And I think Mr. Potter, I'm going to paraphrase this a little bit, but the quote being, "A rate shock claims are a crock." I wonder how he feels about the President's claims about the effects of sequester as he went around the country several weeks before sequester went into effect, and indeed closing the White House tours for our families and young people who are coming to the nation's capital to see the People's House and have an opportunity during upcoming spring break. That being said, I'm going to direct my first remarks to Dr. Holtz-Eakin. Dr. Holtz-Eakin, as a former director of the Congressional Budget Office, you're well aware of how legislative decisions are scored and how they affect our economy. Your current organization, American Action Forum, released a survey which found that for a 27-year-old in Atlanta, where I hang out, the age band compression to a 3-to-1 rating would result in a 27% increase in premiums. Now, these are young people above the age of 27, by the way. Ms. Capps earlier stated that I was ignoring the fact that these young people up to the age of 26, many of them are on their parents' health insurance policy. But we're talking about people that are beyond that. 27% increase in premiums. These individuals, as you are aware, Dr. Eakin, face uncertain job prospects and record education debt. Many of them, of course, stayed in school because they couldn't find a job, and they continued on the Stafford loan program and building up more and more education debt, hoping at the end of that time to be able to find a job. Well, the penalty for not purchasing insurance next year will be $95, and many of these 27-year-olds, 28-year-olds haven't found a job yet. In some cases, a 27-year-old making only $33,500 a year will see premiums increase roughly $800. So, Dr. Holtz-Egan, in your opinion, will young people be more likely to purchase expensive health insurance or pay the relatively low fine next year?
Well, thank you for the question. If I could at the outset, can I just, for the record, make it clear that this survey was entirely my idea. Mr. Potter's insinuated that all such studies are bought by insurance companies. We thought it up. We designed it. We requested the information because of our longstanding interest in this legislation, and the results were delivered in a blind fashion. I have no idea who responded, and the aggregate data were released by us as a matter of public information. What the data say are pretty clear, that if these rate increases take place in markets, it will be cheaper to pay the tax penalty than to purchase the insurance.
Thank you, Dr. Holtz-Egan. Mr. Carson, I'm aware that you have decades of experience as a healthcare actuary. In fact, without you, insurance companies would go broke. In your opinion, if these young people that Dr. Holtz-Egan referenced fail to purchase health insurance, how would premiums react for the rest of the population if fewer and fewer of these young people, beyond the age of 26 particularly, stay out of the market?
Well, even with the current age rating limitations in most states, which is 5 to 1, there is a bit of a subsidy going from the younger generation to the older generation. So we would expect that if those younger individuals do not enroll, if their premium rates are higher than what they are willing to pay, there would be an impact of increasing the rates for the rest of the industry.
Well, let me interrupt you for just a second, and thank you for that answer. I have been chiefly concerned about the effects of the age band compression provisions on these young people we're talking about. And as you know, the 3 to 1 rating does not reflect the true difference in cost of care. You're an actuary. Right now, 42 states have age rating bands of 5 to 1 or more. Do you think that a federally directed age band is the best way to direct costs, or should the states themselves be allowed the option to make actuarially accurate age band laws? And I say that because I feel very strongly that the states should be able to do that. And that's what this bill, the Liberty Act, letting insurance benefit everyone regardless of their youth, is the acronym. If the states don't deal with this, then the default should be 5 to 1. If you, Mr. Chairman, if you'll bear with me and let the gentleman answer that question.
Well, I can't comment specifically on the policy of whether we should allow states to set their own limitations, but I will say that if states are allowed to use a 5 to 1 age rating, as many of them do now, the results of our study would be, in effect, reversed to say that the rates for the younger individuals would be significantly less.
And, Mr. Chairman, this is a bipartisan bill. I would like to, again, urge my colleagues to sign on to it. It solves the problem, and I yield back.
Gentleman's time has expired. The chair recognizes the gentleman from North Carolina, Mr. Butterfield. 5 minutes for questions, sir.
Thank you very much, Mr. Chairman, and thank the 3 witnesses for their testimony today. Today we have another hearing, Impact of Obamacare on America's Health Insurance Premiums. The title makes a lot of sense, Mr. Chairman, if we are talking about how Obamacare brings down the affordable premiums millions of Americans face before the Affordable Care Act, but trying to sell us the story that banning insurance company discrimination and creating a free and fair marketplace will raise premiums, that is just wrong. Now, let's just take a look at a story that will not be uncommon in my district or most districts across the country. Let's say a 35-year-old single man who doesn't smoke and is just above the poverty line, making about $12,000 a year. That's $1,000 a month, $12,000 a year. He doesn't have much savings, and any medical bills would put him in real trouble. Before Obamacare, that constituent could have gone online and found a plan from a big insurance company that cost him $1,400 a year and had a $10,000 deductible, and he would have to pay 30% co-insurance on every dollar of medical care he received. But now let's look at the options after Obamacare. If the governor of my state had been wise enough to expand Medicaid and the legislature wise enough to expand Medicaid, the constituent would have had the option of Medicaid. But on the exchange, the constituent will get a tax credit to keep his premiums at about 2% of his income, which means he will pay $250 a year instead of the $1,400 he would pay for the current plan. He would also be eligible for cost-sharing subsidies that will cut his out-of-pocket spending to around $2,000. So what does that mean? Instead of paying more than $1,400 in premiums, a $10,000 deductible, and a 30% of all costs, the constituent will see his premiums drop to about $250 a year, and he will have a real quality insurance that caps his out-of-pocket spending around $2,000. Now, that is a real savings. And so that's my lead up to my question, Mr. Potter. Let me ask you about this. This constituent that I've been using as a hypothetical will be paying a lot less for coverage under Obamacare, but even if another plan out there offered lower premiums, would it really offer dependable coverage the way plans will under the Affordable Care Act?
The Affordable Care Act is really important to make sure that people are getting, again, value more than they are today. And we need, as we're looking at this, to understand that when we're talking about the cost of insurance, we also, and the cost of care, we have to go beyond just looking at the cost of premiums, too. We have to look at what people's obligations are to pay out of pocket. And so there are limitations in the law that would make these $50,000 family deductible plans a thing of the past. And you're right about your individual that you're using as an example. That individual would be paying less. And also, frankly, most of the people in this that we're talking about, the young people, will also be getting benefits and not be facing these increases, unless for some reason the insurance companies decide and can get away with the price gouging that they seem to be intending to get away with. But most young people will get either they'll be eligible for the Medicaid program or subsidies, because most of these folks have relatively lower incomes. Another thing to keep in mind, too, is that young people don't necessarily want to be uninsured. Many of them don't have coverage now because they haven't been able to afford it. This law will enable many of those people to come into coverage for the first time, so they'll be able to get coverage. It's not that they want to remain naked, as they say in the insurance industry, or consider themselves young invincibles necessarily. They want to get coverage. And I can also guarantee you this, the insurance companies will be spending a lot of money marketing to attract young people. That's where you'll see when the advertising starts, that's a target market that they're going to go after to make sure that they sign up for policies.
So not only does this guy save money on the front end, he saves money on the back end with co-pays and all of the other stuff.
That's correct.
Yeah. Well, thank you, and thank all three of you. I yield back, Mr. Chairman.
Gentleman yields back. The chair recognizes Mr. Griffith from Virginia. 5 minutes for questions.
Thank you, Mr. Chairman. In keeping with what Mr. Shimkus said in regard to, we're trying to figure out, since we didn't have hearings before, we're trying to figure out now where the problems are and where we can fix things. I have been brought to my attention by a constituent at a Farm Bureau dinner that his daughter had a serious problem, and it was brought on in part by Obamacare. She's living at home and is a full-time student, but because she's an industrious young lady, she's also a full-time employee. So she's carrying a full load in college. She's paying for her own way. She's a full-time employee, and because of that, she's not eligible to stay on her parents' insurance because there's insurance offered through her employment, which she would be able to stay on her parents' insurance as a part of the family plan at no cost to herself because they're already paying for mom, dad, and other siblings. But it will cost her, and I don't remember the exact dollar amount, but I recall it being in excess of several $100s per person or excuse me, per this young lady, was going to cost her per month, and is of great expense to her. And so I guess I would ask you, Mr. Carlson, have you heard of similar incidences where, the best intentions of the Obamacare or PPACA plan have actually led to, in this case, this young lady having to spend a lot more money in order to be insured because she's out working hard, going to school, and living at home?
Well, I'm not aware of any specific instances, but what you're describing there certainly is a case that would sound like it makes sense to me and is possible.
Yeah. And, we're just trying to figure out where the problems are, and one of the real concerns, and I'll turn to you, Mr. Holtz-Eakin, is, and Mr. Lance referenced it earlier, the Washington Post recently reported that, that they're not being, a lot of these folks with pre-existing medical problems are going to be blocked from the program that was designed to help them. And in particular, the Post story highlighted the plight of a 60-year-old Virginia woman who wished to only be known as Joyce, who is battling stage 4 breast cancer. And because she didn't know earlier that the plan was available for pre-existing conditions and high risk or high expense, she was trying to fill her paperwork out when she discovered that there was a new deadline that had been applied. And the question is, are we making promises we can't fulfill when we say we're going to cover everybody? And then this lady at the time was swinging in the balance. They don't know whether she got her application in time or not. The Post article says they were going to stop taking new applications on no later than March 2nd. And I contrast that with the fact that the House Republicans had a plan at the time of the passage of this bill that would fully fund high-risk pools to ensure Americans got the treatment that they needed. Now, I guess my question is, if we don't have the money currently to take care of these high-risk individuals with pre-existing conditions, such as this lady who wished to be known as Joyce, do you believe that we should divert funding from other parts of the so-called Affordable Care Act towards these high-risk pools that offset the cost of coverage for chronically ill so that we can actually address the real problems that have existed in our healthcare system?
Well, I certainly believe that this story, while tragic, is hardly a surprise. From the beginning, I've been concerned about the design of the high-risk pools. There were incentives for people to go uninsured, believe it or not, before they could be eligible to become in these pools. They operated side by side with state pools that were often much better designed and got better enrollment. And now they've stopped enrollments entirely. So obviously, there needs to be both a redesign in the criteria for eligibility and the way that the pools are offered, but also the funding and getting funding out of elsewhere in this law, I think would be a sensible thing to do.
And also, I would have to say that if this funding mechanism didn't work as it was promised to work and it didn't have the ability to follow through because they're running out of funding, we also saw the long-term care insurance didn't work exactly the way they thought it was going to work, and they never got it off the ground because of that, which I appreciate pulling the plug when it wasn't going to work. Doesn't that call into question for both you and for just the average human being that if two high-profile parts of the plan didn't fit the model that they said it was going to fit, that the entire PPACA plan is probably going to cost us a lot more money than what the American people were told when it was passed?
I think that's right. I mean, there are two perspectives on that. The first is the notion of fulfilling the promise of affordable care, and here the fundamental problem has not changed. Americans spend not quite 20 cents out of every national dollar on health care, and the Affordable Care Act defines affordable as 10% of your income, which means by definition, not all of us can have affordable health care. And the only way to get people under 10% is to raise someone else's costs, perhaps a lot, and that's done through a variety of taxes, mandates, premium increases, and the law will never add up for everybody in the United States. It cannot. The budgetary costs are extraordinary, and my fear is that it will vastly outstrip the resources that have been devoted to it, particularly if employers follow their incentives and put many more people in the exchanges at higher premiums than we anticipated.
Thank you, Mr. Chairman. I yield back.
Gentleman's time has expired. The chair recognizes the gentleman from New York. Mr. Engel, 5 minutes for questions, sir.
Thank you very much, Mr. Chairman, and thank you for holding today's hearing, Ms. Capps as well. Mr. Potter's testimony is an excellent reminder of the terrible practices routinely employed by the private health insurance industry prior to the passage of the Affordable Care Act, denying children with pre-existing conditions health insurance policies, canceling coverage for people once they became ill, applying lifetime limits to care. These practices were commonplace in the individual insurance marketplace before we passed the law. There are terms we as legislators have all used countless times over the last several years, but Mr. Potter's testimony, which I read, reminds us these things were done to people. Our constituents, they needed health care, and they were denied, and some of them died because of it. Their stories are a sad reminder. It is unacceptable to return to the status quo of the private health insurance industry by repealing the Affordable Care Act. I wanted to say that before I ask my question. Now let me ask this. Private insurance companies have been interested less in insuring those who might actually need care, and instead have worked hard to insure the healthiest and least likely to incur major medical expenses, and that's why I supported a public option in the Affordable Care Act. Unfortunately, we weren't able to get it through, but for my way of thinking, we wanted to ensure that those who are ill, or one of the estimated 129 million Americans with pre-existing conditions, that they have health care coverage. In the absence of the public option, I am very pleased that the strict consumer protections found in this law will be fully implemented by next year. So, Mr. Potter, as someone who's worked in the health insurance industry, do you believe any of the consumer protections, including the age rating requirements as outlined by the ACA, should be changed?
I do not. They're very important consumer protections, and they need to stay in place. They need to be implemented. The insurance companies can accommodate. The law will change the culture of the insurance business for the better. One of the objectives of the Affordable Care Act is to try to get us to a fairer system. The United States certainly has some of the best health care facilities in the world, some of the best doctors in the world. I don't think anyone would dispute that. The problem we have is access to those great facilities and those good doctors. We have one of the most inequitable health care systems on the planet. We rank below Bangladesh when it comes to fairness. So we need to change that. That's one of the objectives here. And in some of these discriminatory practices that have been prevalent in the industry for many, many years, that have led to situations in which people, when they get sick, just can't get coverage. And that could be every one of us in this room or someone we know. We need to keep that in mind.
Thank you. Let me also say that I'm glad that the ACA included rate review requirements for those companies looking to raise their rates by more than 10%. I think it's worth noting that since the rate review provisions went into effect, the proportion of proposed rate increases over 10% declined from 75% in 2010 to 34% in 2012 to less than 15% so far in 2013. And I'm also pleased that the law established clear medical loss ratio, MLR requirements, which have resulted in $1.1 billion being returned to 13 million Americans. So let me ask you, Mr. Potter, I believe the combination of these two provisions are helpful for health premium pricing transparency. Are there additional steps that Congress should take to better ensure a significant portion of patients' premium dollars are being used for medical care and not PR campaigns like the ones you discussed in your written testimony?
I think even more transparency is in order. It's a very good start. But to be able to know how these companies spend our premium dollars, if we're, pardon me, when the individual mandate becomes effective, we're going to be, as you said, we don't have the option of enrolling in a public option. We'll have to be buying coverage for private insurance companies. We ought to know a heck of a lot more about how those companies are spending our premium dollars. So even greater transparency, in my view, with greater granularity about where our premium dollars is going would be something I think that this committee might want to look into.
Well, thank you very much. And let me say in conclusion, the status quo of health insurance plans before the ACA, as far as I'm concerned, was unacceptable. And therefore, I think when we analyze any impact on premiums, it should be a true apples-to-apples comparison, fully taking into consideration the quality and comprehensive nature of plans, as well as taking into account the availability of subsidies for those making below 400% of the federal poverty level. I thank you, Mr. Chairman. I yield back.
Gentleman's time has expired. I recognize the gentleman from North Carolina. Ms. Elmer's 5 minutes for question.
Thank you, Mr. Chairman, and thank you to our panel. Mr. Potter, I have my line of questioning is for you. Are you a healthcare professional?
I have been. I'm not now.
You were. What was your level? What was your title?
I was Vice President of Corporate Communications for Signal Corporation. Before that, I was
Are you a physician?
No, ma'am.
Are you a nurse?
I'm not.
Okay, so you don't actually, you have not earned a degree in any type of healthcare profession.
That's correct.
Okay, well, I am a nurse. Okay, I have been for over 21 years. And I want to go to your example, Ms. Leslie Elder, because I too have a mother and had a mother. My mother died at age 73. How old was Mrs. Elder when she died?
63.
She was 63. And you had mentioned that she had a treatable, chronic but treatable condition, and then I think later you mentioned that she had breast cancer.
She did.
And that she had died of breast cancer.
She died of Hodgkin's lymphoma, as I recall.
So she had a form of cancer.
That's correct.
Now, I'm assuming that she had gotten a diagnosis. She didn't have health care insurance prior to this point.
What happened is her husband was a small business person. He owned an auto repair business.
Did she have, yes or no, did she have health care insurance at the time of her diagnosis?
She did when she was first diagnosed, but after after her initial treatment, the insurance companies raised the rates on the policy so much that he had to drop the coverage.
I had the opportunity very recently to actually visit the cancer center in my hometown of Dunn, North Carolina. And I actually had this very conversation with them. They're doing excellent work. And one of the things that I wanted to clarify was that what happens with someone who gets a diagnosis of cancer if they are not insured? Where does that go and unable to work? And, oddly enough, Medicare disability is something that they can receive. Now, you mentioned also high-risk pools and that, that she and her husband were not aware of that. Is that correct?
That's correct.
And you also mentioned that this was something that she was receiving treatment. Now, it's curious to me as to how she could have been receiving treatment and yet not know about high-risk pools and also not know about the possibility of being put on Medicare.
The high-risk pool was eligible for her toward the end of her life. She was diagnosed with breast cancer earlier.
Okay, and when was she diagnosed with breast cancer?
I don't know the exact year. I think it was around 2002 or something like that.
And she died?
She died last summer. Yeah.
Okay, so she actually had, her length, she lived
She had a pre-existing
years.
condition, that's right, and that's why their premiums went up so much that they had to drop.
Okay,
but
but the availability to get coverage after that was there.
Ultimately, it was.
And they did not take part in it.
They didn't know about it. That's correct.
They didn't know because the health care providers did not. We have discharge planners, we have social services, we have physicians, we have nurses that are giving treatment. I have a hard time believing that this was all taking place and that they did not understand this.
Well, Congresswoman, I would suggest you might talk to Mr. Elder and ask him these questions. I don't know, but I'm told what they...
And you mentioned the daughter, and that the daughter said, and if I can quote you, that if she felt that if Obamacare had been in place, that her mother would not have died. Is that correct?
That's correct.
Do you have a mother?
I certainly do, and she is 88 years old.
And you would like to see her live a good, long life, wouldn't you?
And she has. I've been very blessed.
And that's a blessing. And my mother died at age 73, unfortunately. She had Alzheimer's, but she also received very good care, excellent care, because she had very good coverage. She was also on Medicare, but she still died. And that's a loss. And I understand that Ms. Elder's family is experiencing a loss as well. But I find it curious that you used her as an example of why Obamacare would be such a good plan to be put in place, and that somehow this would have saved her. Is that not what you're claiming?
The point of telling her story was to point, if you look at the written testimony, that they were priced out of being able to offer coverage.
But there was other coverage in fact, and that's
not during most of the time that was available to her.
Health care understand that these reforms have needed to be put in place for a long time, and we're ready to work on those things for healthcare solutions. However, there was other availability there, so I just
not during most
I'm
of
not
the time.
quite sure I'm
not during
I'm
most of the time,
understanding.
Congresswoman.
Not Medicare.
I can, if you would like, I can tell you more about their situation, so you can
Well,
get
no, I don't think we need to.
proper
And my time has expired, but I find your testimony disingenuous. Thank you, sir.
And the gentlelady yields back, and the chair recognizes the ranking member of the subcommittee, Mr. Pallone, 5 minutes for questions.
Thank you, Mr. Chairman. My questions are Mr. Potter. Insurers warn that if they're allowed to charge seniors only 3 times more for coverage than they charge younger people, rather than 5 or 6 or 10 times more, they'll substantially increase premiums on young people. And the Urban Institute recently completed an in-depth analysis of age rating in the ACA and determined these insurer claims to be unfounded. I was going to ask unanimous consent if we could enter into the record this study, Mr. Chairman, by the Urban Institute, which I gave you there.
Without objection, so ordered.
Thank you. So anyway, this Urban Institute study compared the likely results of allowing insurers to charge older Americans 5 times more for coverage rather than only 3 times more, and found that it would, quote, have very little impact on out-of-pocket rates paid by the youngest non-group purchasers once subsidies are taken into account. And the study found that premiums would stay stable for young people because the ACA provides unique coverage options that specifically benefit young Americans. The law provides for a low-cost catastrophic health plan that is available only to people under 30, and it requires that insurers allow adult children to stay on their parents' plans until age 26, a policy that has already expanded coverage to more than 3 million young people. And most important in the study was the fact that young people are some of the most likely to benefit from the ACA's Medicaid expansion and premium tax credits. So, Mr. Potter, were young people served well by the insurance products on the market before reform, or will they be better off because of the ACA's new reforms and consumer protections? And then I'd ask, if insurers get their way and change the age rating ban, do you think they'll stop there, or will they push for other changes?
Young people were not well served, have not been well served, and were not before the Affordable Care Act was passed. They've not obviously had the benefit of any subsidies or tax credits, or the ability to enroll in Medicaid because of the way that the programs are structured right now. So they are going to be much more advantaged as a result of the full implementation of the law than they have in the past. They'll be able to get coverage that's affordable and that's decent. A lot of the policies that insurance companies market to young adults are limited benefit plans or plans with very high deductibles. Young people are not immune from getting seriously ill or injured, so many of them find themselves, if they bought these policies, at great risk of themselves having to file for bankruptcy and their lives being ruined as a consequence.
Let me ask you another question. The health insurance marketplaces that will come online in a few months' time are a key new tool to help consumers and small businesses shop for coverage. They finally make it easy to compare plans, apples to apples, so consumers can purchase dependable quality coverage. Plans will be forced to compete on price and quality. They provide one-stop shop, reduced transaction costs, increased transparencies. The CBO estimates that these factors alone will drive premiums down 7 to 10%, and there's the potential for much more savings. I know my Republican friends like to talk about how the application for premium tax credits will be too long and complicated, but have they looked at insurance company paperwork recently? The ACA eliminates the fine print loopholes that insurers would hide in their 100-page contracts. Instead, it guarantees quality coverage and requires plans to provide a 4-page plain language summary of benefits and coverage. So, Mr. Potter, when you worked in the insurance industry, would you say the industry was transparent and consumer friendly? And what do you think reforms like those in the new health insurance marketplaces will do to consumer costs?
Insurance companies were anything but transparent and forthcoming in the information that they were providing to prospective customers. There's nothing like what has to be available now. You can now make some apples-to-apples comparisons among policies. You could not do that. And you hardly could be able to decipher information except the slick marketing materials you get from insurance companies. But now, as you noted, They have to have summaries that are in.
When you say now, you mean with the ACA?
With the ACA, yeah. That's right.
I mean, look, my own experience, I understand what you're saying, and I really want to emphasize that, part of what the ACA is trying to accomplish is to basically make it easier, with the exchanges, that you can actually figure out what's going on.
You can.
And simplify it. And if you want to just comment on that again.
You can be a much better informed consumer now than you ever have been in the past to buy coverage from insurance companies, because they do have to be more transparent. They have to give you some understanding, or greater understanding of exactly what they will cover and what you might be having to expect in terms of out-of-pocket expenses if you enroll in one plan versus another. And you can do that online. In fact, you can get that kind of information now, because that kind of transparency was required as of the 1st of this year. So, again, I said earlier that these changes are going to be changing the culture of insurance companies in the industry, and for the better. And one of the ways that it's changing the culture is through this greater transparency, which, by the way, the insurance industry fought. They did not want to do this because they've benefited significantly over the years from keeping us in the dark. Okay. That we're buying things that weren't necessarily to our best advantage.
Thank you.
Thank you, Mr. We have a lot of members who are waiting to question before votes. So, gentleman from Florida, Mr. Bilirakis, 5 minutes for questions, please.
Thank you, Mr. Chairman. I appreciate it very much, and I thank the panel for their testimony today. Mr. Carson, as we discussed earlier, how the $100 billion, at least $100 billion tax on health insurance will drive premiums higher. And I know that you have analyzed the tax cumulative impact in depth. Can you explain what it means when you say that the Affordable Care Act constructed this tax to be non-deductible, and why is it a non-standard treatment of taxes?
Well, in very simple terms, the tax is not considered an expense in the in an income statement, so it won't be charged against the company until after their taxes are taken out of their income or what their profitability is. So, in effect, that means that not only do they have to fund the tax, but they also need to fund an additional amount to reflect the taxes that they will have to pay on that. So, as Dr. Holtz-Eakin said earlier, you have to collect $1.50 in premium in order to pay the dollar of the insurer fees.
Thank you. Again, Mr. Holtz-Eakin and Mr. Carlson, the tax on health insurance is one of many factors that will cause the premiums to rise. I think we've established that. There's a real threat that small employers will be forced to terminate employee coverage and send their workers to the exchange subsidized coverage. What will the repercussions be if this happens? And if both of you can give me an answer, I'd appreciate it.
Well, I mean, certainly if you do the arithmetic for any employer whose employees are under 3% of the federal poverty line, it is a no-brainer to stop offering insurance, send individuals to the exchanges. You can give them a raise. They can use the after-tax raise and the subsidies to buy better insurance than you could offer them. You can pay a penalty on top of that and still make more money. And so there are overwhelming economic incentives for a vast number of employees to end up at the exchanges. The implications of that, I think, are pretty straightforward. Number one, the federal budget cost is going to be radically higher than has been estimated to date. Number two, if in fact we see the premiums increase at the same time, those subsidies will increase per person. So again, we get a second hit on the budget cost. This will change the provider networks that many of these individuals will be accessing, and so we'll get disruptions in their care. And the labor market turmoil, I think, will be substantial. And we're beginning to see that with the large number of employers who are moving people to part-time status instead of full-time in order to accommodate the mandate. It's just one of the many potential labor market manifestations of the big implications of this law.
Thank you. Mr. Carlson?
Yes, and I will just add, the $8 billion that starts in 2014 is a fixed number. So if the pool of fully insured premiums that amount is charged against goes down, in effect, the rate will go up. So if you look at our study, we have a high estimate and a low estimate. And the high estimate for the percentage is based on the assumption that employers, especially in the small group market, will drop their coverage and put their employees out into binding exchange or other alternatives. So, and we relied upon industry studies, which in fact said that, is a possibility going forward. So, the more employers that drop their coverage from the fully insured market, the more likely it is that premium rate increase will continue to go up further.
Thank you. Mr. Chairman, I yield back. Appreciate it.
The gentleman yields back. Chair recognizes the gentlelady from Tennessee's Blackburn. 5 minutes for questions, please.
Thank you, Mr. Chairman, and thank you for being with us today. We appreciate this. Mr. Potter, I want to be sure I understood you right. You said that we were charging people so much for health insurance that they couldn't afford to buy it. Before, you made that as a statement that took place before Obamacare. People were being charged so much that they couldn't afford to buy health insurance. Did I understand you right on that?
You're right.
Okay. Let me ask you this then. I've got some stats from people in my district of how their health insurance premiums have gone up since the passage of Obamacare. And I want to just read through these. I've got a car dealership down in Fayetteville. They dropped coverage because the increase is so much. An insulation company with 36 employees in Nashville, they dropped it due to a multiple-year large rate increase in administrative burdens on their plan. A consulting firm with 2 employees, 56% rate increase in 2013, and that followed a 15% in 2012. A restaurant over in Springfield, employees no longer allowed to work more than 29 hours a week. That's a jobs program for you, isn't it? Okay, an auto parts company over in Laverne, okay, they had a management carve-out, but let's see, a 30% increase last year, not going to be able to offer coverage to everyone that works 30 hours or more a week. I mean, the list goes on and on. We've done a flooring company with 30 employees, a 21% increase, and a law firm with 3 employees, a 16% increase this year, 38.5% last year. Physician's office, 7 employees, a 21% increase. A commercial printing company, 25% increase. A manufacturer with 6 employees, a 25% increase. A construction company with 9 employees, 15% increase this year, follow on top of a 42.5% increase last year. Oh, here's a private school with 68 employees, a 17% increase. In a retail flooring store with 5 employees, they had a 123.27% increase that is taking place next month. Sir, what do you tell these employers who are trying to do the right thing? You thought health insurance was expensive before, but what do you tell them now? It's exorbitant?
I might tell them the story of Jim and Leslie Elder, and I don't think it's disingenuous. And we can
No, we're not going to go there. You've sat there and told that story over and over and over. And I have great
because
compassion
it's an important story, and I'm from the great
well,
state of
no,
Tennessee.
sir.
My wife,
it is
my mother
my time, and we're not going to tell it again. I have great compassion for anyone who loses a parent through such a situation. I have just lost my father. And I understand what people go through. But I've got to tell you something right now. I think that what we have to do is look at what is happening to these insurance costs. And here is one I've got. These are all in my district. These are real live numbers that are coming back in. And I can tell you something right now. Have you ever heard of TennCare?
I have.
Okay, we had that in Tennessee, and you know what happened there, don't you? It was a disaster. It was such a disaster that a Tennessee governor, a Democrat governor, had to go in and completely reshape the program. Let me ask you this. Have you ever heard of is there any public option health care program that you can point me to that actually saved money and increased access?
Public option? We don't have any public options in this country.
Oh, that's not what you call you call TennCare. It was the test case for Hillary Clinton's health care. Well, then let me ask you this about guaranteed issue. Right here, I've got in 93, a 30-year-old woman in New York had an average premium let's see, of $1,800 a month. And then New York passed guaranteed issue and community rating. And guess what that premium went to? $3,240. So you go from $1,800 to $3,240. That is a $1,400 a year increase after you insert government control. So if we don't have public option, then have you ever seen a government-run healthcare system that has increased outcomes, decreased costs, and increased access?
Many systems around the world have done a much better job of increasing access and controlling costs and having better outcomes.
My time is about out. Mr. Holtz-Eakin, any examples you can point to there that have lived up to promises?
There are no U.S. examples of that type, ma'am.
Okay. Mr. Carlson? You have none. I yield back.
Gentlelady's time has expired. The chair recognizes the gentleman from Kentucky, Mr. Guthrie. 5 minutes for your questions, please, sir.
Thank you very much. Thank you. Thanks to the panel for being here. And I'd like to build on what some of my colleagues have talked about today and deep concerns over the rising cost of health insurance. The president, when he's pushing the health care law, said it would reduce premiums of a family of four by $2,500. And we've now seen that it's increased by $3,000 per year, and the most expensive portions of the law hasn't been put into place. Has not gone into effect yet, that's what I should say. I come from Kentucky. In the early 1990s, we actually were trying to be before Tennessee, to try to set the standard. In the 1990s, our entire insurance market collapsed in Kentucky. We attempted a guaranteed issue, guaranteed portability, modified community rating. Immediately, like half our insurance providers left. We were down to one. We had to go back and redo the whole law just to get individuals are completely wiped out of the market. Most companies went self-insured just so they could provide health insurance to their employees, so they couldn't afford it. They had to be in the ERISA category instead of the other category. And I would like to think that Kentucky just wasn't isolated. I think we just heard Tennessee's example and one from New York that my friend brought up. And Dr. Holtz-Eakin, is Kentucky, Tennessee, are they the only examples, or are there other?
There are numerous other examples. The state of New York, the state of New Jersey. You can go around the country and look at Kentucky, Vermont, all of Washington State, all of whom have experimented with this and had big premium problems. And in some cases, as in Kentucky, reverse course, having gone through it.
We had to, yeah, because you couldn't get insurance because nobody nobody would even offer it, much less pay the price that it costs. And so we've been there and it didn't work, and now we're trying to do this on a federal level. And I believe even Jerry Brown, the governor of California, in his State of the Budget, so it's not a Republican sitting here trying to say this is an issue. Jerry Brown, I don't think anybody would call him a Republican or conservative, said in the state budget that large rate increases in the individual market are likely, and that's what he put in when he accounted for his budget. And so the way groups will react to the market is something, Dr. Holtz-Eakin, I'm interested in. There was an Oliver Wyman study from 2009 that highlights some significant red flags about the impact of the health care law. And the few things is, as the prices rise, obviously less healthy people have to maintain coverage, and they're least likely to drop coverage even if they absorb the cost because they're less healthy. So then healthy individuals are least likely. I used to say that the only person, a healthy young person over 26, that will have health insurance in America are people who just want to abide by the law because there's no financial incentive to do it because you have guaranteed issue. And then it changed. The law was rewritten by the Supreme Court, as we know, so you're not even violating a law by not buying health insurance. You're paying a tax in lieu of health insurance. So there's no penalty anymore. That was changed by the Roberts Court. But I don't see how premiums won't spiral. The whole concept, Dr. Holtz-Eakin, I'll give you the remainder to talk on this, is you bring young people into the market by mandating coverage, and by younger, healthier people in the market, it brings down the premiums for everybody. You're sharing the risk. But then there's not a financial incentive at all, or even a health incentive because of guaranteed issue for a young person to enter the market. And they're not even mandated to do anymore. They can pay a tax in lieu of going into the market. So would you just comment on how that's going to affect premiums? This premium spiral I'm getting at.
I mean, this is a serious issue. I mean, the whole notion is that you have a base level of premium cost that comes from cost of health care. And there's no way to change that with insurance provisions. And then you want to have a large risk pool to take that national health care bill and distribute it across people. The experience in states has been one in which the combination of guaranteed issue community rating caused the healthy to opt out, and in some cases, we led to state insurance pool death spirals, that continually higher premiums, people leave, and that's been the concern about the construct in the Affordable Care Act. Massachusetts has a similar design, and it's now been widely noted that costs have continued to go up there, and that we're now seeing individuals hop in and out of coverage. The mandate's not working, and I'm worried about it.
I'm going to give this Potter. Do you see the construct of the law is the premium spiral? You don't see this as a threat? The construct of the law for young people to buy health insurance, the incentive is not there for them to buy health insurance. You think young people are going to opt out of the market and the premiums are going to go up? You don't think that's a real concern?
I think we'll just have to see what the real experience is. We can speculate, but I think that, as we said before, young people will benefit from being able to get subsidies. They want to have coverage. I think most people will be wanting to enroll in a benefit plan.
If they're guaranteed issue?
If there's guaranteed issue and a requirement to purchase, the thing that you have to keep in mind is that in some of the states you've talked about, if you have guaranteed issue without any kind of a mandate, which is why the Affordable Care Act was developed as it was.
But the mandate is you can pay a small tax in lieu of paying a premium.
I guess we could argue as to whether or not it's an enforceable or a large enough.
Well, if it's not enforceable, then they're not going to be in the system. That's the point. It's not enforceable.
Now, again, I will say that I think most people want to be covered. It is not that they want to
but
go
as prices rise and they can get it when they need it, why would you pay for it if you can get it when you need it? As prices rise. I mean, I think
because you don't know when you're going to. I might get sick tomorrow, and my son might. My son is not an idiot. He will want to have coverage because he knows that he might get injured. I think most young people realize that they're not bulletproof. They will be getting coverage because they know things like that happen to people.
Gentlemen's time has expired. Appreciate the attendance of everyone who's been at this subcommittee. It's been a good attendance. The ranking member and I will offer one last question to the panel. Recognize the gentleman for New Jersey for 5 minutes.
Thank you, Chairman. My colleague asked if we know of any public health care system that improved outcomes and controlled costs, and I'll certainly give you one. That's Medicare. It has lower administrative costs than private insurance, and it provides great coverage, in my opinion. But I wanted to ask Mr. Potter a question. Opponents of guaranteed issue have tried to compare the ACA's guaranteed issue requirement to previous state experiments with guaranteed issue, and I think this is very misleading. The ACA contains significant premium subsidies and responsibility requirements for individuals and employers. By expanding the pool of who gets covered, the cost increases that critics have tried to associate with the ACA disappear. Massachusetts health reform is probably an appropriate example. In 2006, when it enacted its comprehensive health reform, Massachusetts already had guaranteed issue in place. When the state enacted health reform similar to the ACA, premiums in the state's individual market fell by 40%, while they rose by 14% nationwide. So, Mr. Potter, requiring that insurance companies provide coverage to all who apply represents a big change to these companies' business models. Isn't that correct?
It's absolutely correct. Most of them these days, their business models they're based on underwriting and being able to try to cherry pick and exclude as many people from coverage as possible.
And so do you think there's any comparison between the rise in premiums in states that required guaranteed issue in the 90s and the comprehensive nationwide reforms represented by the ACA?
What the ACA does, Congressman, is taking an approach that is different from what some of the other states took and made the circumstances in those states different from what they will be with the implementation of the Affordable Care Act.
You want to just elaborate on that a little more?
Again, if you have a mandate without, if you have guaranteed issue without incentives to purchase insurance or without a requirement, then there will be people who will opt out, and that does increase the cost of coverage, and it's why the Affordable Care Act was constructed as it is to make sure that more people will have that incentive to purchase insurance.
Right now, opponents, let me ask you one more thing. Opponents of the ACA are attempting to spread fear that the law is going to increase costs for millions of Americans. However, the CBO and other analysis have shown that this notion of market-wide premium increases is simply a myth. First of all, 95% of the insured population in this country has either public coverage or employer coverage, and that's over 240 million people. Every objective analyst agrees that employer coverage will not become significantly more costly under health reform, and a recent study found that increased employer costs associated with health reform were equal to 0.0003% of wages, which is simply too small to legitimately lead to large premium increases. Even the faulty Republican studies discussed today agree that only a subset of that remaining 5% of the market even has the potential to see a premium increase under health reform. So, Mr. Potter, you worked on messaging and public relations at insurance companies. Does it surprise you that this attention and fear-mongering is occurring over such a small segment of the marketplace? And was the individual market before reform a profitable sector for insurance companies?
It doesn't surprise me at all, because it is just a continuation of the same kind of tactics they've used a lot and that I've written about quite a bit. So what they want to do is create an impression of something that is bigger than it is, or even will exist and it might not. So it's exactly what they've done in the past. And the marketplace will change significantly. These companies will change a great deal as well as a result of this. And I think we'll be seeing that coverage will become more affordable. And your point is very well taken, too. It doesn't apply. The vast majority of people in this country, if they get coverage through the workplace or else through the workplace or through a public program, will not see they're not in the individual market. So the effects will be very limited.
All right. Thank you. Thank you, Mr. Chairman.
The gentleman yields back his time. Mr. Carlson, you're the numbers guy. So very quickly, in your experience, has there been any industry where the industry has been force-fed federal dollars that results in lower cost to consumers at the other end?
Not that I'm...
Yeah, student loans come to mind, don't they?
I'm sorry?
I said student loans come to mind, and then some of the problems with the bubble in the housing industry. Force-feeding federal dollars into an industry actually can be quite deleterious, although it seems like it's a compassionate and good thing to do. Mr. Potter, I just have to say I'm so grateful that the gentlelady from North Carolina posed the questions to you that she did. I must say I was reading the testimony last night, and I thought this just doesn't sound like reality. I practiced medicine for almost 28 years. Parkland Hospital, Texas Medical Center, over 20 years in private practice in North Dallas. I cannot, I mean, you're an insurance company. Okay, if an insurance company leaves a patient, the doctor, the cancer center, I mean, those people don't just turn people away. You may think they do, but they don't. We took care of patients every day who had no realistic means of ever paying their bill. I mean, even if it wasn't altruism involved, there's always the threat of medical liability for abandoning a patient, and the family might bring a cause of action. So I just, been racking my brain to think of a comparable clinical situation that I encountered in almost 30 years, and there is not one. And Renee, Ms. Elmers is exactly right. The cancer centers that I know, they would never turn away a patient. You'd find a way to work with them. Maybe find a program at the medical school in the center of the state. Maybe find a facility like MD Anderson Hospital to participate. But you wouldn't just say, well, I'm so sorry about your financial situation. I hope things work out for you. And in reality, that just does not happen. Now, I will say this. I mean, you worked for Cigna in the late 1990s. I mean, Cigna, I think all of the large insurance companies were involved in what were called black box edits, slow pay, no pay, downcoding and bundling, and lowering reimbursement rates to physicians. I mean, the insurance industry during the 90s, I'm glad they're not that way anymore, but they were responsible for some serious stresses on the system, certainly from the perspective of a provider. In fact, providers, really, we could do them a great favor if we would say, when you take care of a person who is in this situation where you are not going to be paid, we will allow you a credit toward your taxable income. And those will have to be negotiated rates, but I think there are ways to deal with the problem. There's always going to need to be safety nets. Safety nets are important. Dr. Holtz-Eakin, I mean, this $16.5 trillion debt, that's not just a theory, that's an application, right? And what happens when the music stops? What happens when The administration goes down to the Bureau of Public Debt to peddle paper on a Tuesday at noon, and nobody shows up to buy.
It's not something you want to contemplate, Congressman.
Right. The interest rates begin to go upward, and they can go upward in a quite dramatic way. You and I will be inconvenienced. It will cost us more to buy a car or buy a house. People who depend on social safety nets are going to be they're going to be clobbered when that day happens. So it is important when we talk about things in terms of federal spending and debt. It's not just an esoteric. It's a reality that people, no one of us, the president, no one in the Senate, no one in the House of Representatives knows when that day of reckoning is going to occur. The president came and talked to House members early this week, and he said, I don't think you all should worry about it so much. That's going to be way in the future. I don't know. I don't have the same confidence that the president has that he can continue to run trillion-dollar deficits every year for another 4 years, and there is no effect on the larger economy, and there is no effect on the dollar being the reserve currency of the year of the world. I think there is going to be an effect. But I find this hearing fascinating because we are perched on the brink of the final rollout of the Affordable Care Act. It is something that's very difficult to contemplate. I don't think HHS is ready by any stretch of the imagination. I think you are going to, you talk about people who are left in the lurch. I think you're going to have a lot of people who go to sign on to sign up on their 21-page application on October 2nd or 3rd and find that the system is not ready for them. The system does not work. You only get one chance to make a first impression. I wish the agency would be more forthcoming to come to this committee and talk to us about where they are in the construction of the informatics piece, in the development of the federal exchanges that are going to have to take place because 26 governors said we don't trust the administration enough to set up a state exchange. I thank everyone for their forbearance during this hearing. I think it has been a good and informative hearing. I have a unanimous consent request, Mr. Ranking Member, to insert an article from the Boston Herald into the record. The headline is Mass Individual Health Premiums Highest in the Nation. I remind members they have 10 business days to submit questions for the record, and I ask the witnesses to respond to the questions promptly. Members should submit their questions by the close of business Monday, April 1st. That's no joke. Without objection, the subcommittee is adjourned.